name is Nina Katangana, and I will be moderating this session for you this morning. Now, we know that the vaccination rollout plan has started. The vaccines for COVID-19 arrived in Namibia around the end of March, and that was the phase 1 that has been rolled out thus far. We'll delve into the nitty-gritties of that in a bit. And we know that some Namibians have been eligible to take the vaccination. So we spoke to, or rather the NMT team spoke to some of these Namibians that have been vaccinated for COVID-19. And we have this video insert that we'd like for you to look at this morning. Just a disclaimer that the views expressed in this video are not of the NMT or the DW Academy, who has joined hands to make this #AskTheExperts sessions possible. But let's have a look at this video.
Good day, fellow Namibians, ladies and gentlemen. My name is Esther Ushua-Mwinyangwe. I am the president of the Nuto Party. I am a member of parliament, and I am the Deputy Minister of Health and Social Services. I'm here to share my experience the day when I took the COVID-19 vaccination. That was on the 19th of March this year, around past 11, and I was the very first person. As a leader, it was necessary for me to do that because we have to lead by example, and someone needed to be the first one, and that person was me. So that was to motivate and encourage Namibians that, of course, we all react differently to any medication. So I was lucky. I did not develop any side effects. And of course, now, this Friday, I think that is the 16th, I will get my second dose, and then I will be, done. And the type of vaccination that I got, maybe that is necessary to mention that as well, is Sinopharm. In conclusion, as a final remark, I would really urge and request all the Namibians who are eligible for the vaccination to go and get vaccinated, because that's the only way we can cap the further spread of the virus.
My name is Frederico Links. I'm the chairperson of the Action Namibia Coalition that advocates for access to information. And I was vaccinated on 12 April 2021 at the Windhoek Central Hospital. The vaccine that I chose to have administered to me was the Sinopharm vaccine, and it is a 3-dose vaccine. And on 12 April 2021, I received my first dose. And with my second dose to come on the 10th of May 2021. The experience was pleasant, although it took a bit of time to go through all the processes, signing, queuing, and then filling in the form that you need to fill into for your eligibility for the vaccine to be assessed. But all in all, it was a pleasant experience. And I didn't experience any side effects then or since receiving the first dose of the Sinopharm vaccine. And I would encourage others who are eligible and who want to get the vaccine, whichever vaccine you choose to get, to go and get vaccinated against COVID-19.
Hi, my name is Arlana Shikongo, and I'm a journalist for the Namibian newspaper. I received my first dose of the Sinopharm vaccine on Wednesday, 7th of April, at Windhoek Central Hospital. The process was extremely easy. Aside from the 30-minute waiting observation period after getting the vaccine, it took about 20 minutes to fill in the form, sign my consent and waiver form, and then be injected with the vaccine. Since then, on the day, I had a little bit of aching in my left arm where it was administered. And thereafter, I felt a little bit of dizziness the days following. Thereafter, I've just felt a little bit fatigued. However, it's been almost a week now, so the fatigue has mostly subsided. The process, the nurses were very encouraging. They were very open about what I needed to know about the vaccine before it was administered. And prior to that, I had just done some research so that I knew what my options were. In Windhoek, we have a couple of options available. You have the choice of Sinopharm, Covishield, which is a form of AstraZeneca, and you are able to choose whichever works for you.
Hi, I'm Omar van Rienen. I got my vaccine on the 8th of April. I got the AstraZeneca vaccine, so my second dose will be in 2 months in June. But my overall experience has been nothing but great. The healthcare workers made sure that the process was seamless and efficient. But most importantly, I do want to send a message to my fellow Namibians out there that vaccines work, they are safe, they are effective, and this is really about protecting your community and the people you love. And only together can we embark on a new normal post this pandemic and build back better as a country. But that starts by doing your part to get vaccinated today and by doing the right thing.
Good morning once again to everybody. So that was the video insert that we watched. The NMT team put that together as they spoke to some of the Namibians who have been vaccinated this far. Now, this is a new session of hashtag Ask the Experts, and of course, today our expert is Mr. Ben Ngombe, who's the Executive Director at the Ministry of Health and Social Services. He is joined by his COVID-19 task team, who also joined us for the conversation last month on the vaccination that we anticipated to arrive before the end of March. We also have Ms. Rosalina De Wee, who is the Epidemiologist Officer at the WHO, joining us this morning as part of the experts team.
Perhaps if I can be accorded the opportunity just to introduce the Ministry of Health team on this side. I am joined here by Ms. Emmy-Elsie Ndevaitela. She's our head of national surveillance for COVID-19. Joined by Ms. Emma Iambo, as well as Mr. Shapumba, who are heading the COVID-19 national vaccination rollout and would speak to issues of logistics and so forth. I do believe we have someone from WHO, and I believe, Nina, you would also introduce them, Ms. Rosalina De Wee, who is quite an important member of our team, who has been advising us throughout the entire process. I yield back to you. I thank you.
Thank you so much, Dr. Kandetu. Yes, I did introduce Mrs. Rosalina De Wee, who is the Epidemiology Officer at the WHO, who forms part of today's expert team. But just to start our conversation, Dr. Kandetu, perhaps to establish some background for today's discussion, give us an overview of the vaccines that arrived in the country last month. Did the arrival process go as smoothly as anticipated?
Again, we thank you really for this opportunity to engage with yourselves, with the media practitioners under the Namibia Media Trust. Since the onset of the national vaccination rollout, the phase 1, we have rolled out and vaccinated over 3,000 individuals in Khomas region and in Erongo region. This is part of the phase 1. We will be commencing with phase 2 on the 19th of April, where we will be now expanding to the rest of the country, hopefully to each and every region. The vaccines that we have in country that are part of the rollout are the Sinopharm as well as the AstraZeneca. I would like to yield to my colleagues here just to expand a bit more on how the rollout has gone in the respective regions and districts. Ms. Iambo, would you like to add some more to that?
Exactly that, as you indicated, Dr. Kandetu, that is exactly where we are at the moment. And maybe just to highlight that the district that we have targeted or having started vaccinating in Erongo is Wavish Bay and Swakopmund, if I can only add something to what the doctor alluded to. Over.
Thank you very much, Nina. Over to you.
Thank you, Dr. Kandetu. Mr. Veer, I understand that you are online. You're joining us via Zoom this morning. And I would just like to pose the next question to you in your capacity as representative from the WHO. Dr. Kandetu just mentioned the 2 vaccines that are available here in Namibia. I just want you to talk to us about the difference between these vaccines. I think a lot of, of Namibians still don't have as much information as they would like. Also talk to us about what the difference are and which we currently have in Namibia for phase 1, and if perhaps it will change with the rollout plan for phase 2, or we stick to the same 2 vaccines that we currently have.
I think the main difference between the vaccines is just the platform that was used to develop the vaccine. I'm sure nowadays on social media, all this information is even available. But the Sinopharm, for example, used inactivated platform, just meaning that they simply take the original virus, inactivate it, and then form a vaccine or produce the vaccine, while the AstraZeneca used the viral vector platform to manufacture the vaccine. But at the end of the day, doesn't matter really which platform is being used to develop the vaccine. The end result is still the same of helping the body to develop antibodies to fight off the infection should you get the infection. So that was the first part of your question. So like I said, I couldn't hear what was the second part on what you were saying, because the network, I think, is really a challenge. Over.
The last part of the question was if we can expect different vaccines to come into the country as phase 2 of the vaccination rollout plan happens.
Okay, thank you. Well, you are sitting with the team of the ministry, and I'm sure they are even in a better position to answer that question. We are always saying, like Dr. Kandetu already mentioned, that we are part of a team called the Scientific and Clinical Evaluation Team, where we continuously look at an update of the vaccines. So I'm sure in the near future, as the vaccines complete the different clinical trials, I'm sure the ministry will look at other options for other vaccines as well, because the more vaccines we can get, the quicker we can end the pandemic together, and also having what we call herd immunity. Over.
Thank you so much, Mr. Veer. Dr. Kandetu, just on that note, perhaps you and your team can respond to that last part of the question, which was if we can expect a different vaccine, with the phase 2 of the rollout plan, or will the country be sticking to Sinopharm and AstraZeneca?
Thank you very much again for the question. The ministry, as Lina there has indicated, will be looking at more than one vaccine product to approach, as she has indicated, herd immunity. Now, as Ministry of Health and Social Services, we have set a target, a vaccination target of 60 to 80% of the Namibian population. And so in order for us to achieve that target, we may not be able to do so just with one vaccine product. So yes, the ministry is looking at other vaccine products in addition to the ones that are already in Namibia, the Sinopharm and the AstraZeneca. We are also looking and we've engaged a number of manufacturers, including the Janssen, Johnson & Johnson, the Sputnik 5 and others. So as Lina has indicated, we do have a very strong multifaceted team of scientific experts who have been evaluating all the scientific data from the vaccine manufacturers out there, and who are on a daily basis feeding this information to us for us to make an informed decision. So in short, yes, Nina, we are definitely looking at other vaccine products. Over to you.
Perhaps you can talk to us about how phase 1 is going. Have you reached your target? Are you on course with reaching your target for the number of individuals you'd like to vaccinate for this phase? Because we do know that only a certain population is eligible for this vaccine. Have you experienced any challenges thus far?
Okay, thanks again. I will just, by way of just giving a brief teaser into the answer, which will really be answered by Mr. Shapumba, is basically just to say the phase 1 is going quite well. We are on track. We are happy with the progress thus far, keeping in mind that we have only rolled out in 2 regions. That's Khomas region and Erongo region. In Khomas region, we've rolled out in Windhoek, primarily at Windhoek Central Hospital and Karutura Intermediate Hospital. In Erongo region, we have rolled out in Swakopmund District Hospital, Walfish Bay District Hospital. Yes, so we didn't roll out in of course, as many districts initially as we had hoped, but we definitely do plan to add more vaccination sites in phase 2, which we would start next week. In terms of the eligibility criteria and some of the other specifics, I do hand over now to my colleague, Mr. Shapumba.
Okay, yes, I think Dr. Kandetu said it all. Probably what I need to add is just to say, like he clearly said, and rightly so, that we haven't rolled out in all the 14 regions, and that's why we do not have probably the number that we expect to have, should we have rolled out in all regions. But for the 2 regions that we have rolled out, so I think so far we are doing quite well. So it's not the big number actually for those regions, but we are doing well. So once we roll out in all the regions, when we'll see how the picture will tell us. I submit.
Yes, thank you, Nina. Perhaps also just to add on the eligibility criteria, that in phase 1 we had indicated to the public that we will focus mainly on those population groups that are high risk. And what we mean by that, the population groups that are at highest risk of developing severe COVID-19 disease, or those who are identified to have high risk of exposure to COVID-19 due to their employment or environmental settings. So initially, those were the healthcare workers, those were individuals below the age of 60 in enclosed settings. We had identified members or who work at points of entry, those who are in the fishing and mining sectors, and so forth. But then as we went along, we did see the need also to include other population groups, such as the journalists, the members of the diplomatic corps, and those in the tourism sector. I do also want to, at this juncture, perhaps indicate that as we progress with the vaccination rollout, we will not necessarily be confined to what has initially been indicated in the phase 1 rollout. As we see it necessary, we will continue to add more and more population subgroups. Over to you.
Thank you.
Yes, I'm sorry, Nina. My colleague, Ms. Iambo, also just wants to add to that, with your indulgence.
All right, just also expanding on what Dr. Kandetu indicated, and maybe also as part of information sharing as we have been doing, and also linking to what Mr. Shapumba indicated, also just to indicate that the public education on COVID-19 vaccination is still ongoing from the Ministry of Health, and that's not only in Commerce region, Erongo, but also beyond the 2 regions, or let me say countrywide, so that the public concern can be heard and be attended to people that are acquainted with the area of vaccination or immunization in general, or COVID-19 as a disease, because that in itself helps a person also to make an informed decision, also considering that vaccination is voluntary. And expanding again, as to say in Erongo we have only picked 2 districts, leaving the other 2 districts out. That decision was done in a strategic manner that the reason we pick Erongo and Commerce was to allow the rollout for them being, and we picked regions that were hardly hit by the pandemic, and we're looking at hospitalization and death at that time. So it just to indicate that for Erongo, Usakos and Omaruru districts are not part of the vaccination at the moment. But as we roll out to the rest of the region, they'll be catered about. And then just also to indicate that the frontline workers and other priority population, as Dr. indicated, are the one we're looking at the moment. And as he indicated that as time goes on, we'll be expanding as appropriate.
Yeah. Over to you, Nina.
Thank you very much. We had one of the journalists put their hand up earlier. David Bishop would like to ask a question. David, if your question has not been answered already in what has been said thus far, please do pose it once again.
I have a question. I am Katharina Moser from the Allgemeine Zeitung. I hope you all can hear me. You said earlier that you plan to roll out more vaccines other than Sinopharm and AstraZeneca, for example, Johnson & Johnson and the Sputnik one. Are there any concrete plans in detail already when these vaccinations could come to Namibia? And are there concrete engagements with the manufacturers?
Yes, thank you very much for that question from Allgemeine Zeitung. So with regards to the Johnson & Johnson and the other vaccine products, we have engaged roughly 7 manufacturers to date to look at how best we can procure these vaccine products in country. Of course, also keeping in mind that the global demand for these products are quite high. Manufacturers to look at how best we can so just also keeping in mind that the supply chain is also quite dynamic. So we have engaged with the vaccine manufacturers, about 7 of them. And so we do expect a response from some of these manufacturers this week. There are also some engagements that are being done above my pay grade that, of course, I cannot speak to. But we are really not leaving any stone unturned in the quest to get more and more vaccines in country. I submit.
Dr. Kandetu, you briefed us just a while ago on the criteria for phase 1 and how you will be expanding on that criteria as you see fit, as you continue with phase 1's rollout plan. I just want to know, just briefly, if you can tell us if phase 2 will have a different criteria, or will it be, as you've said, you adjust it as you see fit according to how the process unfolds?
Thank you for the question. Yes, I failed to also mention in phase 1, we had also included those with comorbid conditions, those with pre-existing comorbid conditions, like those with hypertension, diabetes, chronic kidney disease, cancers, and so forth. Those will, of course, also be included in phase 2. So basically, all the population groups in phase 1, they will automatically also be included in phase 2, with the addition of some other categories. For example, the teachers, those who are also in other sectors that haven't been highlighted in phase 1. But I would like to yield to Ms. Iambo just to expand a bit more on that one. Ms. Iambo.
Thank you for the question, dear team. Actually, we, as indicated earlier, that we, as also as you know, we have what we call Namibia Deployment Vaccination Plan, which is a strategic document that guides us what to do at what time. However, due to situation and circumstances keep revolving, and the science of and the disease itself, the scientists are not hard at work, day and night. And every time we have a subgroup committee that meet and inform us of what has changed and what is no longer applicable. So as indicated earlier, is that as we have phases, but as we see fit and based on the current circumstances or what is the disease and the science telling us, we'll be keeping expanding as necessary, and it might not be as we thought or we stipulated in the plan, but the plan is a mapping just to guide the health workers in the country and the managers involved in the deployment of the vaccine, which other category we need to add to the upcoming phases. And some of the phases will not lapse, will continue into other phases, especially like healthcare workers. We'll be having, for instance, new health workers that got deployed or employed. So we take them on board and we consider the severance, epidemiology curves. So we act accordingly.
Ms. Katangana, just to remind the House that as we are continuing to add more and more population groups, one of the other things that will be guiding us, of course, is the number of doses that are available. We did expand on that at the beginning, that there is quite a large demand globally for these vaccines, and the supply chain, globally, and our access to these vaccines continues to be dynamic. So as we continue to get more and more vaccine doses, we will also start adding more and more population groups, because ideally we would want to vaccinate the 60 to 80% target that I mentioned at the beginning. The limiting factor, of course, would be the number of doses we have in country.
Thank you, Dr. I see Albertina Nakale's hand is up. Albertina, I'll give you an opportunity to pose your question in just a bit. Also, to those joining us via Zoom, you can pose your question in the chat and I will then give it through. I want to give Ms. Veer an opportunity to speak to us this morning. You're quite quiet there, Mr. Veer. Perhaps you can give us your thoughts on what's already been discussed. And I also, because for the sake of time, would like to move on to part of our discussion where we unpack possible third wave that not only Namibia is expecting, but globally is expected, and talk to us about, as you know, a stakeholder in the fight against COVID-19. Albertina, just reminded to please pose your question. The question ready, please. Pose it.
My name is Albertina Nakale from New Era newspaper. My question goes to the Ministry of Health team. I just wanted to find out if they can provide us with a number of doses that are available currently. Of course, that should be now the Sinopharm and the Covishield that were donated by international partners, being India and China. And I want the ministry also to clarify, if I understand correctly, that if, for example, the Covishield doses came 30,000 and every individual who should get a vaccination or who should get vaccinated, I want to believe it's not a single dose. So does it mean now it's 30,000 divided? Does it mean like 2 doses will go to an individual? And it will then mean, does it then mean 30,000 maybe divided by 2 and we only have half of it? Or how does this dose, how do we know how much is available? And perhaps Mr. Kandetu can also tell us how many of these doses have been spoiled, because I want to believe that while they were busy vaccinating, not all these doses were used. And the other thing I want to find out, if the ministry have, for example, recorded any reports of side effects, from the vaccination, these 2 vaccines that have already been administered. And of course, seeing that neighboring Botswana has reported unfortunate incidences of people who have used this Covishield, I want to believe there were 2 deaths reported. I'm not so sure how true this is, but that is a statement that was released by the Botswana government. So we wanted to find out, as Namibian government, just while we are busy administering this same vaccine, maybe is there any report, or are they looking into this issue, or just to really array fears amongst Namibians, as we are already seeing that the vaccination rollout, people are really quite reluctant in getting their vaccines. So yeah, perfect. Thank you, Nina. Over to you.
Thank you, Albertina. Quite a mouthful from Albertina for the Ministry of Health team. Just a request to please keep your response to her brief. We've only got about 10 minutes left.
Yes, we thank you, Ms. Albertina, for your plentiful questions. I just wanted also to get some clarity on the question from Allgemeine Zeitung. I believe that was directed at WHO, just to confirm that. But we will continue answering Albertina's question. So on the first question, we have received via donations now in country 100,000 doses of the Sinopharm vaccine. We have received an additional 30,000 doses from the Indian government of AstraZeneca. Via the COVAX facility, we will also be expecting roughly 67,000 doses of the AstraZeneca vaccine, hopefully by the end of this month. Of course, so those are the doses that have been distributed to the various districts. As far as the second question is concerned, Albertina, yes, you are correct. For Sinopharm and AstraZeneca, we do require 2 doses to complete the course. With regards to the Sinopharm, because it has quite a long shelf life, what we are aiming to do is right now to give the vaccine to as many people as possible. So that is to say, to vaccinate as many people with the first dose as possible, while we are still continuing to get more vaccine doses. The same approach can be applied to AstraZeneca because the interval between first and second dose, as we are informed by our expert scientists, is between 8 to 12 weeks. And so that would also allow us time to get more vaccine doses in country. That's basically just to say our approach here is rather to vaccinate as many people with the first dose as possible, as we are trying to get more and more of these vaccine products. With regards to the third question, you were speaking to spoiled. To date, no spoiled doses have been reported to us, but that is not to say that it hasn't happened. It just haven't been reported to us, but I'm sure one of them can also expand a little bit on that one. The last and final question, I believe, was talking to side effects of the vaccine products. So what we do know as of today is the side effects really are basic, are common side effects that are associated with vaccines. This is, for example, pain at the injection site, headaches, muscle aches, and so forth. These are the common ones, and are also the ones that were shared by via the experiences of the individuals who were interviewed in the video that you just shared. Yes, there is a new development in the scientific community. We have seen and have been privy to reports now from many stringent regulatory authorities, particularly in Europe and in the USA, that as some of these vaccine products are being rolled out in the real world, there seems to be a thromboembolic event or phenomena associated with some of these vaccine products. What we know so far is that this phenomenon seems to be extremely rare. We are talking about 1 in 1 or 200,000 of the population. It is extremely rare, but it has been identified. And it hasn't just been identified in one, but it seems the ones that we know of now are AstraZeneca and Johnson & Johnson. However, as we take heed of this, we are also aware of the fact that the European Medicines Agency, the WHO, as well as other stringent regulatory authorities out there have been looking at reports that are emanating from the countries that are reporting these rare events. They have combed through the data and they are of the opinion, and we are also of the same opinion, that despite this very, very new development, this very, very new and rare adverse event that seems to be associated with the AstraZeneca and AstraZeneca and Johnson & Johnson right now, that is the event of thromboembolic phenomena. The benefits of giving the vaccine still far outweigh the risks. And so the advice here is that we do continue to roll out the AstraZeneca, of course, keeping in mind that we pay more attention to the monitoring and the evaluation, especially of the side effect profile for adverse events as we continue to roll out. But I would also just want to mention at this juncture that we support this advisory, this guidance from the WHO, from the European Medicines Agency and other stringent regulatory authorities on this matter, particularly because, number one, these are extremely rare occurrences, not to take away from the fact that they do happen. It is a concern for us that this is happening, but it has been highlighted as being very rare occurrence so far. And number two, again, the benefits of giving the vaccine far outweigh the risks, as we have mentioned. Over to you.
Thank you, Dr. Kandetu. Well, another question that has come through on our Facebook page, Dr. Kandetu, as somebody was asking, is contact done? Since there's been a decline in the number of cases reported, but an increase in the number of deaths. Yesterday, I believe from the stats that came through this morning, yesterday's statistics showed us that the number of deaths is the second highest since the beginning of COVID-19. So perhaps you can answer that question after Ms. De Wee comes in here quickly.
Thank you, Nina. I didn't get the question that I was contributing to or that I was supposed to respond to, but perhaps while I have the floor, because one of the journalists made reference to the reports of our yes, we are aware also of those two deaths that were reported. It's a 91 and a 90-year-old male and female who both had comorbidities. In fact, both of them were hospitalized and just after discharge requested the vaccine because, as we all know, that they are the vulnerable group, so you would want to take care of them. So the colleagues there are busy doing a detailed investigation, and we can make sure also to share this information so that we are all at ease with what the outcome will be, and also to allay the fears of the public that when events like this are reported, to show that it's been investigated in detail and that the final information can be shared with the public so that we don't seem like we are trying to hide information. So perhaps if you can repeat or put in the chat box what the question was specifically. I think Dr. Kandetu has already elaborated in detail, that the benefits in public health, the benefits outweigh by far the risk involved for getting the vaccines in the event that it could lead to thrombotic events.
Thank you, Mr. Via. While I have you, let me just pose the question to you, and we'll get back to the issue of contact tracing at the end of our discussion. Just to alert everybody, we've added just 15 more minutes. I hope that's all right with all our participants this morning. Mr. Via, my question was about the possible third wave that there has been talks about it, not only for Namibia but obviously globally. And I was asking, as a stakeholder in the fight against against COVID-19, your preparedness for this eventuality.
Thank you. I would rather prefer, I saw Emmy is in the room, or is Emmy not around from surveillance? Because the ministry will be much better placed to respond to this question. Because, with COVID, it is really unpredictable. Yes, countries are having third and fourth and how many waves after. So for that, for the preparation of the ministry for the third wave, I rather have the surveillance colleagues respond to it, because they are very much on top of things and very much up to date with the latest over.
We know that talks of a third wave is coming. I wanted to know what is the preparedness of the ministry in this eventuality. And of course, as Mr. Via mentioned, should this happen, this delays as our ability to reach herd immunity.
Thank you very much. I am joined here by, as I've mentioned, Ms. Emielsi De Wee. She's the head of our surveillance pillar for the whole country. She would answer that question. I would perhaps also, before I yield to her, just expand a little bit on the issue of the deaths. I think it was one question that was asked, essentially to say that the COVID-19 deaths that we are reporting now are among the highest that we have ever reported since the beginning of the pandemic, since the beginning of the outbreak in Namibia. And I just wanted to highlight perhaps 2 or 3 things there. It is true, and it's a great concern for us at the Ministry of Health, that for the past month or so, really, we have been reporting record high numbers of COVID-19 deaths per day. We have also been seeing a steady sort of increase in hospitalizations and ICU admissions. It's a concern for us, number one, because it may highlight the emergence of COVID-19 variants of concern and a possible genetic advantage that these variants of concern may have on virulence. That is basically to say that we are of the opinion, and we are currently studying, that perhaps there is a role that is being played by these variants of concern in the way of increasing the likelihood of patients being hospitalized with COVID-19 severe disease, and increasing the likelihood of them succumbing to COVID-19. And that, of course, is something that we are investigating to see really whether that does play a role here. We do know that the one variant of concern in South Africa, the B1351, seems to be the dominant one that is sparking that is continuing to to bring about hospitalizations and infections and so forth. We also do know that to date, from the data that we are receiving from WHO and CDC and other stringent regulatory authorities, there hasn't yet been a direct link that has been established between the emergence of these variants and virulence. We do know that the emergence of the variants do seem to indicate that the transmission rate is more pronounced, but there hasn't really yet been a link in terms of virulence. And of course, this is now what we are also trying to establish, to see whether some of the deaths that we are reporting here may be associated with variants of concern and a possible genetic advantage they have in the way of virulence. But I believe that Ms. De Wee will also just expand a little bit more on our genetic surveillance initiatives and so forth. Emmy?
Thank you, Dr. Kandetu and the whole team on the question of preparedness by the ministry for this third wave, as it was mentioned. Of course, usually, as just Lena have indicated, when you are having a pandemic or an outbreak of any kind, normally the figures keep fluctuating till the time that you have adequate immunity for the virus not to keep passing on from one person to the other. We have sort of declared our second wave in December when we reached the peak. Of course, our second wave hit us mainly July, August. Then we had sort of a break in terms of number of cases. We had few cases around October, November. Then our cases started picking up with our highest number of cases we reported during Christmas Day. Then the numbers had been fluctuating. Of course, they came a bit down as compared to that peak during Christmas, but they started picking up again because of the situation which we had been seeing or hearing among the learners. Those are the cases which we had been having. It's very difficult to say we are preparing for the third wave. We might be in the third wave already because, as I said, our cases, the second wave peaked in December, January, but February, we have seen a big ditch in when you look at the curve, then it started picking up again in March. It didn't go as high as it were in December, but we are still hoping to have to see more on the downtrend. Though the concern which we are having now, though the number of cases are not much as compared to December, is the number of deaths and number of severe cases which we are reporting on a daily basis. Of course, as we are responding to the pandemic, as the ministry, we continue to strengthen the health system capacity. So that is preparedness, moving continuously. You are being strengthen your preparedness at the same time as you are responding. This had been also manifested. If you look at the way we had the regulations had been, you might wonder why we are having these cases, but the situation we are having this is because you have to balance with the social sector. You cannot keep tighten the public health measures as much as you are depriving on the economic sector and the livelihood. We needed also to strike that balance. What we had been doing and we continue to do is to strengthen the health capacity to be able to continuously respond even to the highest wave if we have to have the highest peak at any point to come. And this we have been doing in terms of staffing, the number of staff, which we have in terms of recruitment, keeping the volunteers, which we were given at least allowed to keep on board as a government to support with these interventions. Infrastructure, including now the number of isolation beds. As you have seen, if you are having many cases on admission, you don't want to find yourself in a scenario where the patient is with COVID, he needs admission, but he cannot be taken in by any hospital because all isolation beds are full to capacity. Those are the preparedness measures which we continue to keep up, and also to make sure that we have adequate oxygen supply as we are increasing the bed capacity, and also the ventilators when it's needed. The other area also, as we are continuously increasing strengthening the system, is the testing capacity. We have been increasing the testing capacity in terms of the number of the laboratories which we are testing. We started from 0, then we went to 1 up to 10 numbers of the laboratories which are testing now for COVID. So, and these are not, the focus is not only to increase the laboratories in Windhoek, but at least to increase also across the whole country, so that we have, the whole population is having access to timely testing. Then the next one also, when it comes to increasing the lab capacity, is the implementation of the antigen rapid diagnostic testing. We are aware that we have the RDT kits, the antigen RDTs, which are already approved for use by the WHO. We have run the validation in country, and they have passed the sensitivity and the specification levels which the WHO has set. But of course, since they were validated in the controlled in laboratory environment, one of the recommendations which came from the lab NIP, which have validated the kits, is to do again the field verification, just to make sure that if you are using this, testing this at point of care, meaning now at health facility, not in the laboratory setting, then you still have that level of sensitivity and the specification which is required. And that is a process which we are busy with this week. We believe by next week we will be done with this process of field verification. And we are also confident that it will really give us the result which is expected for us now to roll out the antigen rapid diagnostic testing in all the regions. So now we are doing the field verification in Windhoek. So the public education is also one area which is continuous. We need our nation to still continue with understanding and adhering to the advice which are being given. Concern swabbed for a reason probably that you are having symptoms, or maybe you had been in contact with a infected person, but people are still traveling before it might be positive, and that person, when you are looking for the person to disclose the result and to determine whom had you been in contact with, this person had already traveled to another end of the country. It's not really a recommended idea. I then take this opportunity also to encourage that whenever the person is swabbed, it's better to limit, or if possible, to avoid traveling before your result is out. Because in case you are infected, you are further transmitting the disease and exposing more people. Dr. Kandetu talked about the surveillance sequencing. The other capacity as witness is to increase the capacity in country to do the sequencing, the genome sequencing, at least to be able to identify which variant are we having circulating in the country. Dr. Kandetu have alluded to the variant of concern already, which was first detected in South Africa. And it's obvious that we have some evidence that that variant is circulating here. We are still trying to collect more information so that it's really representative figures which we are talking, so that we can determine how is the magnitude of different variants which we have. We are sending samples to different laboratories outside the country, but we are also increasing the capacity in country using the local labs to do this genome sequencing for us to continuously determine how the virus is changing itself, so that we are always on top of the game in terms of response. I pause here.
Thank you very much, Ms. Ndivayitela. Thank you very much, Nina. And thank you once again to the colleagues who are online. We look forward to the next engagement. Goodbye.
Thank you so much, Dr. Kandetu. We are out of time this morning. Thank you for that elaborate response that you gave us. It's very informative. Ms. Rosalina De Wee, thank you so much for joining us as well this morning. This is obviously an ongoing discussion in this platform. We'll be back again next month to further elaborate on what is topical concerning COVID-19. So to Dr. Kandetu and his COVID-19 task team and all the participants this morning, we thank you so much